Discuss the four phases of pharmacokinetics and how they impact the efficacy of respiratory medications in patients with altered physiology, e.g., patients with liver or kidney impairment. Answer: pharmacokinetics encompasses the processes of absorption, distribution, metabolism, and excretion of drugs. Absorption: this phase refers to how a drug enters the bloodstream. Factors such as gastric pH and gastrointestinal motility can significantly affect absorption. In patients with altered physiology, such as those with gastrointestinal disorders, absorption rates may be reduced, leading to diminished therapeutic effects of medications like bronchodilators or corticosteroids. Distribution: after absorption, the drug is distributed throughout the body. Volume of distribution can be affected by body composition changes in the elderly or those with renal disease. For instance, increased body fat may result in prolonged half-lives for lipophilic drugs, potentially leading to toxicity. Metabolism: the liver plays a critical role in drug metabolism, where drugs are converted to more water-soluble compounds for excretion. Patients with hepatic impairment may have decreased metabolism of certain respiratory medications, e.g. theophylline, necessitating dosage adjustments to prevent toxicity. Excretion: the kidneys eliminate drug metabolites from the body. In renal impairment, drugs such as aminophylline require careful monitoring, as decreased excretion can lead to accumulation and adverse effects. Explain the mechanisms of action for short-acting beta-agonists, SUBAs, and their role in managing acute asthma exacerbations. Include potential side effects. Answer: short-acting beta-agonists, SUBAs, such as albuterol, act primarily on beta-2 adrenergic receptors in bronchial smooth muscle, leading to bronchodilation. This action helps alleviate bronchospasm during acute asthma exacerbations. Mechanism of action: when a SABA binds to beta-2 receptors, it activates adenylate cyclase, increasing cyclic AMP (CAMP) levels. Elevated CAMP relaxes bronchial smooth muscle, leading to dilation of the airways. Indications: SABs are indicated for quick relief of asthma symptoms and are often used as rescue inhalers. Side effects: common side effects include tachycardia, tremors, headache, and hypokalemia. These effects are due to beta-2 receptor stimulation, which can cause systemic vasodilation and potential hypokalemia from increased potassium uptake into cells. Understanding the pharmacodynamics and potential side effects of SABs is essential for safe and effective management of asthma. Mr. Thompson is a 72-year-old patient with a history of COPD and chronic renal insufficiency. He presents to the emergency department with worsening shortness of breath and a new prescription for a long-acting bronchodilator. Considering his medical history, what should Mr. Thompson discuss with his healthcare provider regarding his medication management? Answer: Mr. Thompson should address several key points with his healthcare provider. Renal function: given his chronic renal insufficiency, Mr. Thompson needs to ensure that the prescribing clinician considers renal dosing adjustments for any medications, particularly long-acting bronchodilators, which may accumulate and increase the risk of side effects. Side effects monitoring: he should discuss the potential side effects of the bronchodilator, particularly cardiovascular effects such as tachycardia and arrhythmias, which can be more pronounced in elderly patients and those with renal impairment. Therapeutic monitoring: Mr. Thompson should inquire about the need for therapeutic drug monitoring, especially if the bronchodilator has a narrow therapeutic window, such as theophylline, to avoid toxicity. Comorbid conditions: it would be prudent for him to discuss the interaction of the bronchodilator with any other medications he is currently taking, as well as any other conditions that may affect drug efficacy and safety. Involving patients in their medication management discussions can enhance compliance and improve outcomes. How does the therapeutic window of a drug impact the administration of respiratory medications, and what strategies can be employed to maintain this window in patients with varying pharmacologic responses? Answer: the therapeutic window is the range between the minimum effective concentration (MEC) and the minimum toxic concentration (MTC) of a drug. Maintaining this window is crucial in respiratory care to ensure efficacy while minimizing toxicity. Impact on administration: in patients with altered pharmacokinetics, such as those with liver or kidney impairment, the therapeutic window may be narrowed. For example, patients with renal failure may require lower doses of medications like aminophylline to prevent toxicity. Strategies for maintenance: dosing adjustments. Regular monitoring of drug levels can help adjust dosages to keep them within the therapeutic range. Patient education: teaching patients about the importance of adherence to prescribed regimens to maintain effective drug levels is vital. Use of long-acting medications: in some cases, switching to long-acting agents may provide a more stable pharmacokinetic profile, reducing the risk of fluctuations in drug levels. Compare and contrast the advantages and disadvantages of using metered-dose inhalers (MDIs) versus nebulizers for delivering bronchodilator therapy in patients with severe asthma. Answer: both MDs and nebulizers are common devices for delivering bronchodilator therapy, but they have distinct characteristics. MDIs advantages: portable and easy to use, require less time to deliver medication in a precise dose. Disadvantages: require coordination for effective use, so patients must be able to inhale at the right time. Limited to certain patient populations, e.g., may be challenging for young children or severely ill patients. Nebulizers advantages: can deliver larger volumes of medication. Useful for patients who cannot use MD due to coordination issues or severe respiratory distress. May provide more consistent delivery of medication over a longer duration. Disadvantages: less portable and require electricity or battery power. Longer treatment times can lead to decreased patient compliance, risk of contamination, and need for regular cleaning. The choice between MDs and nebulizers should be individualized based on patient needs, severity of condition, and ability to use the devices correctly. Discuss the mechanism of action of macrolides and their role in treating respiratory infections. Include potential resistance mechanisms. Answer: macrolides, such as azithromycin and clarithromycin, are a class of antibiotics that primarily inhibit bacterial protein synthesis by binding to the 50s ribosomal subunit, preventing peptide bond formation. This action effectively stops bacterial growth. Role in treatment: macrolides are particularly effective against respiratory pathogens such as Streptococcus pneumoniae and Haemophilus influenzae. They are often used to treat community-acquired pneumonia and exacerbations of chronic bronchitis. Resistance mechanisms: resistance to macrolides can occur via several mechanisms. Methylation of the ribosomal RNA. Alteration of the binding site on the 50s ribosomal subunit can prevent macrolide binding. Efflux pumps: some bacteria may develop efflux pumps that expel the drug from the cell before it can exert its effect. Enzymatic degradation: bacteria may produce enzymes that hydrolyze the macrolide, rendering it ineffective. What are the considerations for using neuromuscular blockers in mechanically ventilated patients? Discuss the implications for patient safety and monitoring. Answer: neuromuscular blockers, such as succinylcholine and rocuronium, are often used in mechanically ventilated patients to facilitate intubation and optimize ventilation. However, their use requires careful consideration of several factors. Indication: neuromuscular blockers should be used only when necessary, such as in patients requiring sedation during procedures or those with severe respiratory distress. Monitoring: continuous monitoring of neuromuscular function is critical to avoid prolonged paralysis. The use of peripheral nerve stimulators can assess recovery from blockade and guide dosing. Patient safety: it's essential to ensure that sedation is adequate before administering neuromuscular blockers, as these agents do not provide analgesia or sedation. Patients must be monitored closely for signs of inadequate sedation, which could lead to awareness during paralysis. Complications: potential complications include residual paralysis, which can lead to respiratory failure post-extubation, and risk of deep vein thrombosis due to immobilization. Overall, the use of neuromuscular blockers must be justified, and patient safety should be the priority through proper monitoring and support. How do the schedules of controlled substances impact the prescribing of respiratory medications, particularly those used in sedation and analgesia? Answer: the scheduling of controlled substances is essential for regulating the prescribing and dispensing of medications, especially those with potential for abuse, such as sedatives and analgesics used in respiratory care. Controlled substance schedules, Schedule I, no accepted medical use, e.g. heroin, Schedule 2I, potential for abuse, severe psychological or physical dependence, e.g. morphine, fentanyl, Schedule II, IVV, low potential for abuse compared to Schedule II with decreasing levels of control. Impact on prescribing: medications classified as Schedule I require strict documentation, special order forms, and limited refills, usually one time. This restricts access and ensures careful monitoring of usage. Schedule M and Thal medications have fewer restrictions but still require careful consideration of potential for abuse, especially in patients with a history of substance use disorders. Describe the key factors to consider when monitoring therapeutic drug levels in patients receiving theophylline therapy for asthma management. Answer: theophylline is a methylxanthine used for asthma management, requiring careful monitoring due to its narrow therapeutic index. Key factors include therapeutic range. The typical therapeutic range for theophylline is between 10 to 2 mg/ml. Levels outside this range can lead to either insufficient control or toxicity. Patient factors. Age. Pediatric and elderly patients may metabolize the drug differently, necessitating closer monitoring. Comorbidities. Conditions like heart failure or liver disease can alter theophylline metabolism, increasing the risk of toxicity. Drug interactions. Theophylline metabolism can be affected by other medications, e.g., certain antibiotics and high seizure medications that either induce or inhibit CYPA enzymes. Clinicians should regularly review the patient's medication list for potential interactions. Signs of toxicity. Symptoms of theophylline toxicity include nausea, vomiting, arrhythmias, and seizures. Monitoring for these symptoms is critical for timely intervention. Discuss the pharmacologic considerations in administering respiratory medications to pediatric patients. What unique challenges do healthcare providers face in this population? Answer. Pediatric patients present unique challenges in pharmacotherapy, particularly in respiratory care. Dosing adjustments. Pediatric patients often require weight-based dosing due to differences in body composition and metabolism. Calculating appropriate doses based on body surface area or weight is essential to avoid underdosing or overdosing. Formulation availability. Many respiratory medications are not available in formulations suitable for children, leading to difficulties in administration and adherence. Liquid formulations or inhalers with appropriate spacer devices are often necessary. Developmental considerations. Younger children may lack the ability to effectively use inhalation devices, e.g., MDIS, DPIS, requiring alternative delivery methods like nebulizers. Patient education for caregivers is vital. Adverse effects. Pediatric patients may have different side effect profiles and risk factors for adverse effects from respiratory medications. For example, prolonged use of corticosteroids can impact growth. In summary, understanding these considerations allows healthcare providers to tailor respiratory care to meet the specific needs of pediatric patients effectively. A 58-year-old patient with chronic obstructive pulmonary disease, COPD, is admitted with acute hypoxemia. The physician prescribes oxygen therapy to maintain a target SPO between 88–92%. Which oxygen delivery device would be most appropriate for this patient and why? Answer. For patients with chronic obstructive pulmonary disease, COPD oxygen therapy requires careful titration to prevent complications such as hypercapnia and respiratory acidosis. The Venturi mask is the most appropriate device for this patient due to its ability to deliver a controlled FiO, typically ranging from 24% to 40%. This mask uses color-coded adapters to ensure a specific oxygen concentration, allowing for precise adjustments based on the patient's needs. The American Thoracic Society recommends targeting an SPO of 88–92% in COPD patients, recognizing that higher oxygen concentrations may lead to co-retention due to diminished hypoxic drive. This is particularly critical during acute exacerbations when patients are vulnerable to respiratory failure. Monitoring for oxygen toxicity, which can occur with prolonged exposure to high oxygen levels, is also essential. In patients with chronic respiratory failure, it is vital to observe for signs of hypercapnia, such as altered mental status or respiratory acidosis indicated by elevated arterial CO levels. Thus, the Venturi mask not only facilitates effective oxygen delivery, but also mitigates the risk of further complications associated with oxygen therapy. A respiratory therapist is assessing an elderly patient with severe asthma. The patient experiences difficulty coordinating breathing with a metered-dose inhaler MDI. Which alternative aerosol delivery device would be most suitable for this patient, and what factors must be considered? Answer. When assessing a patient with severe asthma who has difficulty coordinating, the use of a metered-dose inhaler MDI and nebulizer is the most appropriate alternative for aerosol drug delivery. Nebulizers convert liquid medication into an aerosol mist that can be inhaled easily, requiring no specific inhalation technique, which is particularly beneficial for patients with acute exacerbations or those unable to perform the necessary coordination with an MDI. Factors to consider when selecting a nebulizer include the type of medication prescribed, the patient's ability to tolerate a prolonged treatment session, and their overall clinical status. Nebulizers are particularly effective for delivering bronchodilators and corticosteroids during acute attacks, as they allow for higher doses of medication to be administered over a longer duration. In terms of infection control, the Centers for Disease Control and Prevention (CDC) provide guidelines emphasizing the importance of proper cleaning and disinfection of nebulizers between uses to prevent bacterial contamination. This aspect is critical, especially for patients with compromised respiratory systems. Mr. Thompson, a 70-year-old patient with acute respiratory distress syndrome (ARDS), has been intubated and requires mechanical ventilation. His ideal body weight is estimated at 70 kilograms. What initial tidal volume should be set on the ventilator, and what guideline supports this choice? Answer: in Mr. Thompson's case, who has been diagnosed with acute respiratory distress syndrome (ARDS), the recommendation for setting the initial tidal volume is based on the principle of lung protection. The ARDSNet protocol advises using a low tidal volume strategy of 4 kg of ideal body weight IBWA to minimize ventilator-induced lung injury (VILI). Given Mr. Thompson's IBW is estimated at 70 kilograms, this translates to a tidal volume setting between 280 ml and 420 ml. This low tidal volume approach is critical in ARDS management, as it helps prevent barotrauma and volatrauma associated with high tidal volumes. Elevated tidal volumes can cause further injury to already compromised lung tissue, leading to worse outcomes. Moreover, adjusting P-positive and expiratory pressure levels is vital in maintaining alveolar recruitment and preventing collapse. The use of low tidal volumes and appropriate P aligns with the evidence-based practices outlined in the ARDSNet studies, which demonstrate improved survival rates when these strategies are employed. Regular monitoring of plateau pressures is also crucial, as keeping these pressures below 30 centimeters high helps mitigate the risk of VILI. List at least 3 key criteria that a patient must meet before extubation is considered according to evidence-based guidelines. Answer: before extubation, specific criteria must be met to ensure patient safety and minimize the risk of reintubation. According to the American College of Chest Physicians and other critical care guidelines, these criteria include adequate oxygenation. Patients must have a power of at least 6 mHg, a fraction of inspired oxygen equals 80%. This ensures that the patient can maintain adequate oxygenation without high levels of supplemental oxygen, stable hemodynamics. The patient should not require high doses of vasopressors. Hemodynamic stability indicates that the cardiovascular system is capable of supporting the patient's respiratory efforts post-extubation. Effective cough and secretion clearance. The ability to cough effectively is essential for clearing any retained secretions, reducing the risk of post-operative pneumonia. Patients should demonstrate an effective cough and a passage prior to extubation. Successful spontaneous breathing (SBT). The patient should successfully complete an SBT, which typically lasts for 3:120 minutes, demonstrating adequate respiratory effort without distress. In which situations is high-frequency chest wall oscillation (HUO) particularly beneficial, and what are some contraindications to its use? Answer: high-frequency chest wall oscillation (HUO) is particularly beneficial for patients with conditions that lead to thick secretions, such as cystic fibrosis, chronic bronchitis, and certain neuromuscular diseases. HFCWO involves the application of rapid bursts of air delivered to the chest wall, creating oscillations that help to loosen mucus from the airway walls, facilitating its clearance. The effectiveness of HFCWO is enhanced by its ability to provide a non-invasive method of secretion mobilization, which is especially crucial for patients who are unable to cough effectively. This technique is supported by guidelines from the American Association for Respiratory Care (ARC), which endorse its use for patients with inadequate airway clearance. However, there are contraindications to consider. HFCWO should not be used in patients with unstable pulmonary conditions, such as recent lung surgery or significant pleural effusions, where oscillations could exacerbate these conditions. Additionally, recent rib fractures pose a risk of further injury with chest wall oscillation. Therefore, clinicians must evaluate the patient's overall status and specific needs before initiating HFCWO therapy, ensuring that the benefits outweigh the risks. MS. Garcia, a 60-year-old with a tracheostomy, frequently develops thick secretions that are difficult to clear. The clinical team is considering using a heated humidifier. What is the rationale for this choice, and what benefits does it provide over a heat and moisture exchanger (ATEMI? Answer: for MS. Garcia, who has a tracheostomy and experiences thick secretions, using a heated humidifier is highly recommended over a heat and moisture exchanger (HME). Heated humidifiers provide a consistent and high level of humidification, delivering nearly 100% relative humidity, which is critical for maintaining mucosal integrity in patients with artificial airways. This level of humidification is particularly important for liquefying thick secretions, thereby improving airway patency and reducing the risk of blockage. In contrast, HMEs are passive devices that may not provide adequate humidity for patients with heavy secretions, as they can become occluded, rendering them ineffective. The inability of HMEs to adequately humidify can lead to complications such as mucus plugging, airway obstruction, or infection due to inadequate clearance of secretions. The American Thoracic Society, its guidelines emphasize the importance of adequate humidification for tracheostomized patients to prevent complications associated with dry airway secretions. Continuous monitoring of secretions and humidification effectiveness is essential. Should thick secretions persist despite adequate humidification, further assessment may be needed to determine additional interventions, such as increased frequency of suctioning or adjusting humidification settings. What are the main strategies used to prevent ventilator-induced lung injury, VILI, and why are they effective? Answer: preventing ventilator-induced lung injury (VILI) involves several key strategies aimed at minimizing lung damage during mechanical ventilation. The primary strategy is implementing a low tidal volume ventilation protocol, which recommends tidal volumes of 4 kg of ideal body weight IBWA. This approach reduces the risk of barotrauma and volatrauma, which are common complications associated with high tidal volumes. Maintaining appropriate PEE, P-positive in expiratory pressure levels is also crucial in preventing atelectasis and maintaining alveolar recruitment, thus improving gas exchange without excessively increasing airway pressures. The appropriate use of PEE helps to reduce the incidence of VII by preventing the repetitive opening and closing of alveoli, which can cause further injury. Additionally, monitoring plateau pressures is vital. Keeping these pressures below 30 centimeters high helps minimize pressure-related injuries to lung tissue. Regular assessments of oxygenation and ventilation parameters, along with adjustments based on patient response, are essential to ensure effective lung protection. For a patient with moderate asthma requiring bronchodilator therapy during an exacerbation, compare the advantages of using a metered-dose inhaler (MDI) with a spacer versus a dry powder inhaler (DPI). Answer: when delivering aerosol therapy to a patient with moderate asthma experiencing an exacerbation, the choice between a metered-dose inhaler (MDI) with a spacer and a dry powder inhaler (DPI) is critical. An MDI with a spacer is preferred, especially in acute situations, because it improves drug delivery by reducing oropharyngeal deposition and ensuring that more medication reaches the lungs. The use of a spacer also aids patients who may struggle with the coordination required for effective inhaler use, allowing for more efficient inhalation and better therapeutic outcomes. Studies have shown that the combination of MDI and spacer can significantly enhance lung deposition of inhaled medications compared to using an MDI alone. In contrast, while DPIs are effective for many patients, they require a strong and rapid inhalation effort, which may not be feasible during an acute asthma attack when the patient may experience shortness of breath or weakness. Moreover, if a patient is in respiratory distress, the additional effort needed for a DPI can hinder effective medication delivery. Guidelines from the Global Initiative for Asthma (GINA) emphasize the importance of optimizing inhaler technique to ensure effective drug delivery. What are the critical elements of tracheostomy care to prevent infection and maintain airway patency? Answer: in the context of long-term oxygen therapy (LTOP) for a patient with chronic respiratory disease, the necessity for humidification and oxygen delivery is crucial, particularly when high flow rates are utilized. When delivering oxygen at flow rates exceeding 4 Lmin, humidification is recommended to prevent the drying of mucosal surfaces and to assist in the clearance of secretions. The American Thoracic Society, its guidelines recommend the use of heated humidifiers or bubble humidifiers in patients requiring higher flow oxygen therapy, especially when the duration of oxygen therapy is extended. Adequate humidification is vital for maintaining airway moisture, reducing irritation, and facilitating mucociliary function, which is essential for clearing secretions effectively. Without proper humidification, patients may develop complications such as thickened secretions, mucosal damage, or increased risk of respiratory infections due to inadequate airway clearance. Additionally, dry oxygen can lead to discomfort and exacerbate existing respiratory conditions. It is essential to monitor the patient's response to therapy regularly, assessing for any signs of irritation or difficulty in secretion clearance. Mr. Anderson, a 65-year-old patient on mechanical ventilation for pneumonia, is undergoing a spontaneous breathing trial (SBT) to assess readiness for extubation. Despite stable vitals, he reports mild fatigue and discomfort. Should the SBT continue, and what parameters must be evaluated to determine his readiness? Answer: for Mrs. Johnson, who is on mechanical ventilation after surgery and has a history of COPD, the choice of ventilation mode should prioritize both comfort and adequate ventilation. In this case, pressure support ventilation (PSV) would be an ideal choice. PSV allows the patient to initiate breaths while providing a set level of pressure support, which assists in overcoming the resistance of the endotracheal tube and reduces the work of breathing. PSV is particularly advantageous for patients with COPD as it allows for variable tidal volumes based on the patient's inspiratory effort, facilitating a more natural breathing pattern. This mode promotes patient comfort and reduces the risk of respiratory muscle fatigue, which can be a concern in patients with compromised lung function. Moreover, the American College of Chest Physicians emphasizes the importance of patient ventilator synchrony to optimize outcomes in mechanically ventilated patients. Additionally, incorporating spontaneous breathing trials (SBTS) when she demonstrates readiness for weaning can help evaluate her capacity for independent ventilation. What factors should be considered when assessing a patient's medical history for respiratory health? Answer: when assessing a patient's medical history for respiratory health, several factors should be considered, including past medical history, previous respiratory conditions, e.g. asthma, COPD, pneumonia, hospitalizations, and surgeries related to the respiratory system, family history, any familial prevalence of respiratory diseases such as asthma, lung cancer, or interstitial lung disease, which may indicate genetic predispositions, lifestyle factors, smoking history, duration, frequency, type, occupational exposures to irritants, e.g. dust, chemicals, and environmental factors, e.g. air quality, exposure to allergens, symptom history, duration and severity of symptoms like cough, dyspnea, and wheezing, which can provide insights into the current respiratory condition. This comprehensive approach helps in identifying risk factors and tailoring management strategies for optimal patient care. How can healthcare professionals effectively identify abnormal respiratory findings during a physical examination? Answer: healthcare professionals can identify abnormal respiratory findings through systematic examination techniques such as inspection, observing the patient's breathing patterns, use of accessory muscles, and any signs of respiratory distress, e.g. cyanosis, palpation, assessing for tactile fremitus by placing hands on the patient's chest and asking them to say 99. Decreased fremitus may suggest pleural effusion, while increased fremitus may indicate pneumonia. Percussion, tapping on the chest wall to assess the underlying lung density. Dullness may indicate fluid accumulation, e.g. pleural effusion, while hyperresonance could suggest pneumothorax. Auscultation, listening to breath sounds using a stethoscope. Normal sounds like wheezes indicating bronchoconstriction, crackles suggesting fluid or secretions, or diminished breath sounds potentially indicating obstructive processes are key indicators. Recognizing these findings is essential for diagnosing respiratory conditions and formulating appropriate treatment plans. What is the significance of arterial blood gas (BAG) analysis in managing respiratory conditions? Answer: arterial blood gas (BAG) analysis is critical in managing respiratory conditions because it provides essential information regarding oxygenation status, measured by POW levels, indicating how well oxygen is being transferred into the bloodstream. Low levels can signal hypoxemia, necessitating supplemental oxygen or ventilation support. Ventilation status, evaluated by POCO levels. Elevated CO indicates hypoventilation, while low levels suggest hyperventilation. Understanding CO levels aids in determining the need for mechanical ventilation or respiratory support. Acid-base balance, assessed through pH and bicarbonate. HEO levels. Metabolic acidosis or alkalosis can indicate underlying metabolic disturbances, while respiratory acidosis or alkalosis may arise from ventilatory issues. Interpreting these parameters guides treatment decisions, such as adjusting oxygen therapy, initiating bronchodilators, or administering bicarbonate in cases of severe acidosis. A scenario where Mr. Smith presents with an acute asthma exacerbation, what immediate interventions should be prioritized? Answer: in the case of Mr. Smith experiencing an acute asthma exacerbation, the following immediate interventions should be prioritized. Administer short-acting beta agonists (SOBAs). Quickly provide a SABA such as albuterol via a metered-dose inhaler or nebulizer to relieve bronchospasm and improve airflow. Assess vital signs and oxygen saturation. Monitor respiratory rate, heart rate, and oxygen saturation using pulse oximetry to evaluate the severity of the exacerbation and guide further interventions. Provide supplemental oxygen. If oxygen saturation is below 92%, initiate supplemental oxygen therapy to ensure adequate oxygenation. Consider systemic corticosteroids. If Mr. Smith's condition does not improve rapidly with bronchodilators, systemic corticosteroids, e. Prednisone may be administered to reduce inflammation. Reassess. Continuously monitor Mr. Smith's response to treatment, repeating assessments of breath, sounds, peak flow measurements, and vital signs to determine the effectiveness of interventions. What are the indications for referral to a pulmonary specialist in patients with chronic respiratory conditions? Answer: referral to a pulmonary specialist may be indicated in patients with chronic respiratory conditions for several reasons, including uncontrolled symptoms, patients with persistent or worsening symptoms, e.g., dyspnea, chronic cough despite optimal management, indicating the need for advanced treatment options or re-evaluation of the diagnosis, complex comorbidities, individuals with multiple comorbidities, e.g., cardiovascular disease, diabetes, that complicate the management of their respiratory condition may benefit from a specialist's expertise. Need for advanced diagnostics when advanced testing such as high-resolution CT scans, bronchoscopy, or pulmonary function tests beyond standard assessments is required to accurately diagnose or stage the disease. Consideration for advanced therapies, patients being evaluated for surgical interventions, e.g., lung transplantation, or advanced therapies, e.g., biologics for severe asthma, should be referred for specialized care. Assessment for clinical trials. Individuals interested in enrolling in clinical trials for novel treatments or therapies related to their chronic respiratory conditions may need specialist referral. How do pulmonary function tests (PFTs) contribute to the diagnosis and management of respiratory disorders? Answer: pulmonary function tests (PFTs) play a pivotal role in diagnosing and managing respiratory disorders by assessing lung function. PFTs measure lung volumes, capacities, and airflow rates, helping to determine the presence of obstructive e.g., asthma, COPD, or restrictive e.g., pulmonary fibrosis lung diseases, evaluating severity by providing quantitative data on forced vital capacity (FVC) and forced expiratory volume in 1 second. PFTs assist in classifying the severity of airflow limitation, guiding treatment decisions, monitoring disease progression. Regular PFT enable healthcare providers to track changes in lung function over time, assess treatment efficacy, and make necessary adjustments to management plans. Determining reversibility. In asthma patients, bronchodilator responsiveness is evaluated by performing PFTs before and after administering a bronchodilator, aiding in distinguishing between asthma and other conditions. Preoperative assessment. PFTs are essential in preoperative evaluations to assess a patient's respiratory fitness and identify any potential risks associated with anesthesia and surgery. What is the importance of recognizing signs of respiratory distress in patients? Answer: recognizing signs of respiratory distress is crucial for several reasons. Early intervention. Early identification of respiratory distress allows for prompt interventions, potentially preventing the progression to respiratory failure or other severe complications. Patient safety. Monitoring for signs such as increased respiratory rate, use of accessory muscles, nasal flaring, or cyanosis is vital in ensuring patient safety and appropriate management during acute episodes. Guiding treatment decisions. Observing changes in the patient's condition can inform healthcare providers about the effectiveness of ongoing treatment, indicating whether adjustments are necessary, facilitating timely referrals. Patients exhibiting severe signs of respiratory distress may require urgent referral to specialists or advanced care facilities, ensuring they receive the appropriate level of care. Improving outcomes. By recognizing and addressing respiratory distress early, healthcare professionals can enhance patient outcomes and overall satisfaction with care, contributing to better recovery rates and quality of life. What laboratory tests are commonly used in the evaluation of respiratory diseases? Answer: several laboratory tests are commonly used in the evaluation of respiratory diseases, including complete blood count (CBC), used to assess overall health and detect infections or inflammatory processes. Elevated white blood cell counts may suggest infection or an inflammatory response. Sputum culture helps identify infectious agents in patients with productive coughs, aiding in the selection of appropriate antibiotics. Arterial blood gas bag analysis measures oxygen and carbon dioxide levels in the blood, providing critical information about respiratory function and acid-base balance. Chest X-ray. Although not a laboratory test per se, imaging is essential for evaluating lung pathology, detecting infections, masses, or structural abnormalities. Pulmonary function tests (PFTs) quantitatively assess lung function, measuring airflow and lung volumes to differentiate between obstructive and restrictive diseases. These tests collectively contribute to a comprehensive evaluation of respiratory diseases, enabling accurate diagnosis and effective management strategies. What are the potential complications of untreated pneumonia? Answer: untreated pneumonia can lead to several serious complications, including respiratory failure. Severe pneumonia may cause significant impairment of gas exchange, leading to respiratory failure that may necessitate mechanical ventilation. Pleural effusion. Infection can result in fluid accumulation in the pleural space, potentially leading to emphysema. Infected pleural effusion that may require drainage. Lung abscess. Localized collections of pus within the lung tissue can form, requiring antibiotic therapy and possibly surgical intervention. Sepsis. Pneumonia can spread bacteria into the bloodstream, resulting in sepsis, a life-threatening systemic inflammatory response that requires urgent medical intervention. Long-term lung damage. Recurrent or severe pneumonia episodes can lead to chronic lung issues such as scarring or bronchiectasis, impacting long-term respiratory health. Awareness of these complications highlights the importance of timely diagnosis and treatment of pneumonia to mitigate risks and improve patient outcomes. How can vaccination reduce the incidence of respiratory infections? Answer: vaccination can significantly reduce the incidence of respiratory infections through several mechanisms. Preventing specific infections. Vaccines such as those for influenza and pneumococcus target specific pathogens known to cause severe respiratory illnesses, reducing the overall incidence of these infections. Herd immunity. Widespread vaccination within a community decreases the overall prevalence of disease, protecting those who are unvaccinated or at higher risk. Elderly immunocompromised, reducing severity. In vaccinated individuals who do contract respiratory infections, the severity of illness may be lessened, leading to lower rates of hospitalization and complications, lowering transmission rates. Vaccination reduces the likelihood of infected individuals transmitting pathogens to others, thereby controlling outbreaks of respiratory infections. Protecting vulnerable populations. Vaccines contribute to the health of vulnerable groups by lowering the risk of outbreaks and ensuring that those with weakened immune systems are less likely to be exposed to infectious agents.